Welcome to the IMWG conference series, coming to you today from Vienna, Austria. I'm Brian Durie. To my left is Ola Landgren, and to his left Joseph Mikhael, and to his left Paul Richardson. And we are very pleased to be here today and to discuss current topics. The reason that we are here is that we have just an hour and a half ago completed the IMWG summit where we've been discussing the latest questions and trends in myeloma. We have had the recent data presentations at ASCO. We also have the upcoming presentations at the EHA meeting, which is happening here in Vienna in the next few days. And so we have a lot of new data. We have data that has been emerging within the last 6 months to a year. And so we have a number of very topical pieces of information that deserve further comment and discussion. What we've picked as key questions for today are listed here. We're going to discuss diagnostic criteria, new diagnostic criteria, which were published toward the end of 2014 and have been a topic of ongoing discussion in terms of this new approach to diagnosis and the full implementation of these criteria. We will be talking about a new revision to the ISS staging system as a baseline for evaluating patients at diagnosis, and also something that was a very important topic for discussion here at the summit. Where do we stand with the option to utilize a personalized medicine approach? A major focus was where are we with MRD testing and how will that impact our response criteria? A particular discussion as far as therapy focused on the challenge that we now face in patients who are refractory to the novel agents that we have been using in recent years, and focusing particularly on what we call double refractory disease. And a new topic discussed for the first time at our summit is drug costs, the escalation of drug costs, and how this impacts the access to treatments, the optimal treatments around the world today and increasingly in the coming years. And so if we turn to the first topic, the diagnostic criteria, after considerable thought and review of all of the data, a paper was published with Dr. Vincent Rajkumar as the first author, published in Lancet Oncology this past November of 2014. And it comes up with recommendations to implement new criteria for the diagnosis of myeloma. And so what are the details of these criteria? Well, the shift is toward what are called myeloma defining events. And so what has occurred is that instead of waiting for the symptoms and signs of myeloma to emerge, we're now focusing on what we are calling a biomarker approach, where we're going to use changes that have occurred prior to the development of the traditional CRAB criteria. And the events that have been selected thus far are a more sensitive assessment of kidney function, creatinine clearance. For a small percentage of patients, those who have a high level of plasma cells in the bone marrow but have not yet developed CRAB criteria, those who have an increased serum free light ratio, and those who have evidence of active disease. In the primary case in this in the MDE setting is having 2 or more focal lesions, so greater than 1 focal lesion present on MRI. Now, with this use of additional imaging, it has triggered questions about, well, what is the role of PET-CT scanning, and what is the role of whole body low-dose CT scanning in the setting of this enhanced imaging evaluation of patients at this early stage of disease? And so the questions that I have for my distinguished panel today is, yes, we're really pleased about these new diagnostic criteria. So how important is this new biomarker approach in terms of our ability to start treating patients earlier? But have there been any particular challenges in switching to this kind of new biomarker approach? So who would like to touch on this first? Joe,
sure. I'm happy to jump in anytime,
all right.
Brian. So, I mean, I think the approach, the concept is important. You know, we've always defined myeloma by the presence of organ damage, but we know that there's a pre-organ damage phase. You know, the analogy I use is, if I see my friend running towards a cliff, do I have to wait until they're falling off the cliff to try and rescue them?
Right.
So if we can, with this, note how far away the cliff is and how fast they're running, then we can catch them. On the other hand, if we see that the cliff is miles away, it's a beautiful sunny day here in Vienna, and they're walking slowly, we may not have to intervene right away. So I think just the concept of not waiting for people to have kidney damage or bone damage is an important step forward for us.
Right. And so, and I would assume that Paul and Ola, you would agree with that?
Yeah. There was a paper published in March from Scandinavia. I was involved in that, where we had followed patients with 6,000 patients with MGUS. They were followed over time, and some of those individuals over years developed myeloma. And there were also patients who were diagnosed with myeloma without knowing they had MGUS. That was the majority.
Right.
And then survival analysis were done to look to see whether there was a difference in survival if you had been followed for MGUS and then developed myeloma versus you were just diagnosed up front.
Right.
And survival was between 10 and 15% better among those patients that were followed and then subsequently diagnosed. And this is simply because you were diagnosed at an earlier stage.
Yeah, so that with closer monitoring, there was a chance for earlier intervention.
You capture. And then in parallel, there was a study in the US published around the same time showing exactly the same thing. So I think having two studies showing that early detection is reflected in 10 to 15% better overall survival, that I think confirms that we are on the right path in terms of starting disease treatment earlier for the disease, in my opinion.
So you have any issues with that? Is that?
No, I broadly agree. I think Joe's analysis that I use a similar metaphor. I think it's my patients are walking on a cliff path. Why do you have to wait for them actually to fall across the cliff? And I think that's critical not to do that. And I think the key point is gauging at which juncture that path is going in a direction in which treatment is warranted. And I think at that same point, what we now have in our armamentarium are medications and drugs that can actually be used earlier with very much more favorable tolerability profiles than we ever had before, and with a biological rationale to their use that makes them very attractive in the early disease setting.
Right.
And I think particularly attractive is the immunological approaches early. We know that in smoldering disease, for example, the immunological repertoire is in a different state than it is in the more advanced setting.
Right.
And so there's an opportunity, for example, for antibodies, vaccines, immunomodulatory drugs to have more of an impact. And I think in that context, to be able to do more in terms of therapeutic benefit with less in terms of actual treatment has obvious benefits for patients in the longer term.
Yes, yes. So obviously in the past there has been criticism and concern that immunotherapy approaches might be expected to work the best early. Right. And so now this does give that opportunity for earlier diagnosis and earlier intervention to particularly focus on the immune strategies.
And but I think, you know, defining carefully where we are is so important, because the risk is always twofold, either to go too early or too late.
Yes.
So we also want to make sure that although we've moved in a direction to catch patients earlier, to intervene earlier, we also want to make sure we don't intervene too much too early.
Right.
So this doesn't, because I know that some of the reaction to our new criteria have been, oh, doesn't this mean now we're going to be treating all MGUS patients? If anything, no. And what we're defining is those patients at highest risk of smoldering disease that really truly have myeloma or about to develop myeloma.
Right.
And so that's potentially one of the traps. Is
yeah,
to
so just to pick up on that point, in terms of problems or possible challenges, I think this has come up related to the use of the free light. Using a simple blood test to just say the free light ratio is equal to or greater than 100, the free light chains in the blood. I've had some reaction from clinicians saying, well, you know, how comfortable are you that when it reaches this magic number of 100, that's a reason to treat a patient? Have you had any concerns about that?
It's come up several times, I know. And first of all, I always make sure that people know it's involved over uninvolved greater than 100. So if it's in most systems, if it's a kappa light chain, it would have to be, 100 times higher than the lambda, but same for 100 times lambda over kappa, although we don't usually calculate a lambda over kappa ratio. But it's a spectrum. We all know that those light chains, they can be pretty finicky and they can bobble along. So one single measurement over 100 might not make me immediately say we need to treat. I might say, what's the context? Is there a trend towards it? Because otherwise, again, we don't want to risk the error of jumping in too early, but we don't want to wait too long.
No, I agree, Joe. And I think the important point about the absolute number is also just what you've alluded to is the context. I have a number of patients in whom I've seen that number, and I've looked back at them and said, my goodness, they've been quite stable for a long period of time. So I tend to watch those markers, look, and just get the aggregate picture. And I'm also struck that there are subtle symptoms that go with smoldering high-risk disease that are not obvious. Fatigue is common, arthralgia, sort of rheumatoid-like symptoms that can mask this sort of immune dysfunction that can be a hallmark of evolving myeloma. And I think that I'm on the lookout for those types of things because I've been very struck in some of our trials that we've done in this population that we've been able to actually make people feel better with our interventions. A particular example, we've had a very interesting experience with elotuzumab monotherapy in smoldering patients. Not only have we seen responses that we didn't see in the more advanced setting, but we've seen symptomatic improvement as well from subtle symptoms that would not meet the old criteria and so would not justify saying this patient has quote-unquote symptomatic active myeloma, when in reality they weren't feeling great, and when you treated them, various symptoms improved.
Right. Good points, yeah. I would say that I've had possibly the most questions about the imaging piece, is that we now are shifting from routine x-rays to be saying that patients with high-risk smoldering myeloma or smoldering myeloma should be getting an MRI done, for example. And so there are questions and concerns about the use of the MRI and then also about the interpretation of the MRI. What is a lesion, and is that lesion myeloma? Is that lesion maybe a hemangioma, or how do we view that? So what's been your experience with that aspect? You want to start with that?
Yeah, so these are very good questions, and this is an area that's currently under development for sure. I think radiology experts are not fully done with the interpretation on how to define these lesions. So this is an area where there is some kind of work to be done. So I think on a clinical note, I think the key message in my opinion is if doctors are not sure about the finding, the first thing to do is to probably repeat the imaging maybe in 3 months rather than acting on it.
So that is, just to be clear, that is in the criteria, is that if there's a question that the first thing to do would be to repeat in 3 months. So this is a strong point, yes.
And I think it's the same thing that Joe and Paul brought up for the light chains. If the light chains go up once over 100, repeat it is probably the right thing to do, unless there has been a trend of it going up. If it's a blip, but this is how we do clinical medicine and have done for years. So be careful.
Right. Another nuance to this is that it does shift, and we're going to be talking about this later, but it does shift some of the costs and access issues as well. So that if you do an MRI at the baseline, that does raise that commitment to be monitoring and following up with subsequent MRIs. And so there is a shift towards the utilization in a broader way of the higher level imaging.
Yeah, and I think that's important because as Ola mentioned, we're still trying to better define how we image myeloma in general.
Right.
And so I think one of the important messages is that we're not doing this kind of imaging on every patient with MGUS, for example. Right. Just because they have a small monoclonal protein doesn't warrant them getting it, but we're really just trying to catch that higher end spectrum. Because some of those people will have very abnormal findings in the MRI or a PET scan that will make us say, oh, maybe this would cause us to treat. I would say in the patients that we've looked at in this last year since the revised criteria have come out, that there haven't been that many that imaging has completely pushed us over the edge. So I do also want to make sure we're cautious and not just image everybody because you know, it's like when you image, you're going to find something abnormal that may be entirely unrelated to the myeloma, may not even be really abnormal. Right. But the criteria are there because there was good evidence for them. So I agree with you that it should be done. I would say that now there seems to be evidence people can do either an MRI or a PET. Although my slim crab criteria, as I call it, uses the letter M for MRI. But I do think that we don't have to be doing all of these different kinds of images in the same patient.
Right. And yeah, so at the summit here, there was a lot of discussion about other elements of imaging which don't exactly pertain to this, but the use of whole body low dose CT, for example, instead of routine X-rays. So I think that what we can see is that there are going to be ongoing modifications of how we use imaging in the next year or two as these things move forward.
Right, I agree, Brian, and I think that the important piece that I find in my practice in smoldering patients I do use is if I see subtle changes in bone that may just be reflecting early osteopenia, I'm very comfortable, particularly based upon some of the more recent data with bisphosphonate use, particularly the Myeloma 9 trial from the United Kingdom, using bisphosphonates relatively early. And I'm particularly interested in that because I think on the one hand, obviously it's a microenvironmental effect on bone. Two, as long as one's judicious about the potential for side effect issues. But I'm also fascinated by there is an immunological effect of bisphosphonates on gamma T cell subsets. And so as we think immunologically, I'm kind of struck that it is reasonable. We have randomized data in the smoldering population to show clinical benefit for bisphosphonate, recognizing that it's subtle, it's not overt. But I'm also intrigued by the data from the Mateus trial, where if you look at the control group, who did very poorly actually, and the survival difference was so striking in favor of the lenalidomide-treated patients. If you looked at the events that drove the inferior outcome of the control group, bony events dominated, and I think it's worth making remembering that. So certainly in our own practice, we're very comfortable if we see any evidence of early bone mineral density lost. Or any subtle changes of using bisphosphonates in conjunction with other protocol-directed approaches.
One element of that trial was that perhaps the use of more enhanced imaging in that control arm would have actually picked up progression earlier.
We know in patients that are diagnosed with smoldering myeloma, where the skeletal survey is negative, doing a low-dose whole-body CT will detect lesions in a third of those individuals. So there is no doubt that more advanced imaging will pick up early disease.
And so we didn't have it in that particular trial, and I think it could have affected the balance between the two outcomes.
Absolutely.
Okay, so I think why don't we move on to our second topic. There are two elements to this. One is a new revised ISS staging system, which is coming along, will be coming out in the Journal of Clinical Oncology shortly. And then what was quite an emphasis at this summit here in Vienna, how should we be approaching the use of a personalized medicine approach to treatment, particularly in the clinical trial setting right now? And so if we look first of all at the new revised international staging system developed primarily by Antonio Palumbo and the Italian team, but with significant collaborations. The simple way of looking at this is that they took the traditional ISS staging system based upon serum beta-2 microglobulin and serum albumin, and added to that the cytogenetic and FISH information and LDH. And so basically, if you have standard abnormal chromosomes or negative FISH findings and normal LDH, that would enhance the sensitivity in the stage 1, and obviously for the ISS stage 3, high risk plus a high LDH would give you an enhanced stage 3 assessment. And so it's just a refinement, and you can see that the curves are pretty smooth. It does give quite good discrimination between these three patient groups. And so the question is, at this point in 2015, with these kinds of diagnostic and prognostic tests, how do you view this? I mean, this is a minor improvement. It's certainly something that we can add in relatively easily within a clinical trial setting. But how do you view this sort of enhancement? Ola, what about you?
Well, I think it's beautiful work. I think the curves are smooth. I do also think that in 2015 we have all these new drugs and we have a lot of data, if you look back to see how powerful therapies have been applied to different risk groups. I think the difference in the past with powerful drugs compared to now is that the new powerful drugs are not necessarily as toxic. So I think you could justify in the past that you could hold back with the powerful drugs because of toxicity. You could spare those patients with a better prognosis and maybe say that you shouldn't give them all the toxicity. But now we have these powerful drugs that are not so toxic. So my opinion is that you should give the best drugs to all the patients and not scale back because the biology is less adverse. And my bottom line is that I think those individuals have the highest likelihood of benefiting from the best therapy.
Right.
On the other hand, I do think that this information is highly important for the interpretation of data on clinical trials. So to study results and to stratify, to make sure that the two arms, if you have a randomized study, are equally balanced, so the results are not driven by factors like this. So that's how I view it. And on a clinical note, I use it more as a prognostic factor to understand the trajectory of the disease, but I would not use it for therapy myself. I don't know what Paul and Joe.
Yes. So I take that point, and I think in talking to patients, I think that this information is very helpful in guiding the way that you might present the baseline information when all those results come back from the lab and you're meeting with the patient. This is very helpful, obviously.
Yeah, no, I agree. I mean, I agree and I disagree with Ola, but I mean, I agree with the concept that sometimes I tell patients there's two stages of myeloma.
Yes.
The stage that needs to be treated and the stage that can be watched. Right?
Okay.
But so I agree that it's not necessarily guiding therapy but this is very excellent work. And I think we all recognize that myeloma is more than just beta-2 microglobulin and albumin. I mean, it's time that we had cytogenetics. In fact, instead of calling it the revised ISS, because you know me, I'm the acronym guy, I've come up with a new acronym for this.
Really?
BLISS.
Blitz.
BLISS. So B is for the bone marrow cytogenetics. The L is for the LDH. And the ISS is the same ISS as before. Right? So and I'm not sure this is quite blissful, but we'll take bliss for now.
Okay, I think Antonio might be quite pleased.
Yeah, Antonio, I mean, that's one thing Antonio and I might agree on. But on the other hand, to Ola's point that theoretically, now that the drugs are less toxic, which is wonderful, and I support that, that we should necessarily then still have as an aggressive approach in lower risk patients sounds good, but until we have that evidence, I'm not sure that we can say that for sure.
Right.
But I definitely agree with him that this isn't going to change therapy, I don't think, our therapeutic approach, but it's going to give us a better informed prognostic tool. And that's what the ISS usually has been used for, and helpful in clinical trials, you're right, because we can capture this information in trials. Because as we know, different systems have incorporated MRD, for example, plus ISS or now BLISS, and those kinds of complex tools may be helpful in certain situations. But I think it is a step forward, and I'm thankful that we've been able to collect that information.
Right.
Well, I think it is useful. I think that certainly from the point of view of therapeutic choices, I agree entirely with Ola that it makes no sense to be therapeutically parsimonious in an incurable disease. Well, what it means is that for your higher risk patients you need to do more, but for your quote-unquote standard risk patients you need to do as much as you reasonably can. So I would be very struck that, for example, in the group who have adverse cytogenetics, I would want to make sure that in my combination approach, I had drugs that optimally targeted mutational thrust. For example, I'd make sure proteasome inhibition was part of it. I would consider participation in trials in which, for example, there might be a monoclonal antibody that might be part of that study, which, as we know, is agnostic to adverse cytogenetics in a very favorable way. So I think there are implications from this revised staging system that will provide us with not just a clue to how these patients may do, but over time may guide us in therapeutic choices, recognizing that I agree with you, Joe, right now, would this versus another make me not offer a 3-drug regimen? No, other considerations would guide me, tolerability, convenience, and so forth. So I think that it's an important step forward. I totally agree that it takes us above ISS. I will say, though, that, in credit to the ISS, what a remarkable system that provided us with a real bedside tool. And I think that, enormous credit to Phil Gripe and the team who originally did that work, and enormous credit, as always, to Antonio and the IMWG for going up this next step. I think, interestingly enough, from a patient perspective, this is very tangible as well. And I think I'm struck that some of my patients are getting rather confused by gene expression profiling, 70 versus 100. What does it mean? You know, is it the sword of Damocles?
Right.
Well, this is much more practical and I think more helpful in that regard. And I always say that a fool with a new tool is still a fool. And at the end of the day, you know, we need to know what these tools really tell us before we can start to absolutely guide patients in one direction or another. So I think that's kind of helpful as we frame it. But I agree with you, Joe and Ola. This is an important step forward.
So what I'm going to do now is to switch from the simple to the more complex. And so what was a topic at the summit and invoked a lot of discussion was, where are we with personalized medicine? And so if we switch to a much higher gear and look at where are we at the molecular level in understanding myeloma. From a simplistic standpoint, it sounds great. You identify the genetic lesion, and then you come up with a test and a treatment for that. Very simple, right? Well, not so simple. The summary of the genome sequencing, for example, for myeloma shows that there is no unifying mutation. The most frequently occurring mutation is found in only 30% of patients. And there's a shift from thinking about those mutations to maybe pathways that maybe contain collections of mutations. So a lot of discussion about that. And then if there is what has been discussed as an actionable mutation, one in which we might have some treatment option, such as the BRAF mutation here, which occurs in 4% of myeloma patients. How should we approach that? And what has actually been the initial experience in targeting this kind of a mutation? And then what about what has become a big topic, clonal tides, intraclonal heterogeneity, the fluctuations at baseline, and over time as different therapies and sequencing of drugs has occurred. And so there are ways of trying to capture this, and one system that has been developed in the Mayo system is to come up with a custom mutation panel, which is targeted towards some of the more common mutations that have been observed. And you can look at these in different ways: the recurrent mutations, actionable genes, the pathways, and then those targeting drug resistance to particular drugs. And so several ways of looking at it. And so a lot of discussion about whether this would be a good tool to integrate into upcoming clinical trials. And so at the summit here, and I'm going to ask our panel just 2 or 3 of the questions that came up. So at the summit, this was a listing of topics for discussion. And so maybe we can just start at the top here. So should this kind of mutational analysis approach be included now in clinical trials? Are we to the point where we need to be starting to look at this? We talked about ISS, bliss, but are we here? Who wants to take this one first?
Me? Oh, thank you. Wow, this is a difficult one for sure. Well, I mean, we know from these studies that have been published the past 18 months that probably the standard patients diagnosed with myeloma has maybe 10 or so more parallel myelomas going on in the body at the same time, molecularly.
Yes.
And when we treat, I do think that there could be some of these myelomas that we actually already are curing, while some are not.
Yes.
And that's when the recurrent disease comes back. And they are so molecularly different. So now, coming back to your questions here, do you need to study this in every trial? It's very expensive to do it. So I think my answer to that is no. But I do think for newly diagnosed studies, I think it's important. And I think for certain studies, that could be a reason to do longitudinal monitoring. So I think we need to do some more thinking and defining where we want to go with these very expensive technologies, because they are almost as expensive as the drugs.
Yes.
So we don't have unlimited resources. We're going to talk about that later.
Yes.
And that applies also to the trials. And the trials, they are bringing up the cost for the drugs when they eventually hit the market.
Yes.
So we have to be thoughtful when we design these types of studies, I think.
Yeah, I agree with you. I don't think we're quite ready to introduce them in the vast majority of trials. I think
Right.
we're still at the collection phase. I mean, even as you've listed here, you know, there are different ways of doing this. And I think what we're learning is that myeloma is so complex. There's so many genes turned on and turned off that I think what we need is more collection of this information. It's not quite ready for prime time. And I think you made an excellent point, Ola, that what we're learning in the work that we've done and presented at this last ASH and have published is it's one thing to get a photograph of a patient's disease at one stage or at one point in their career, myeloma career, but it changes over time. And that can be very helpful. That's where we can see it. Certain genes disappear and then come back. You know, the concept of clonal tiding, or of certain ones that later in the stage of the disease tend to be a little bit more turned on, like the BRAF mutations tend to be a more later event. So because right now the results of what we're finding don't immediately intervene with treatment, I'm not sure it's quite ready to incorporate into trials. But if larger centers that have large tissue banks can collect this information and we get a better sense of the different pathways, you know, we think about our actionable drugs or actionable mutations as we've mentioned. Sadly, that's still in a very small percentage of people, but hopefully with time, if more drugs can be matched to those pathways, we'll have more for them. So I'm excited about the fact that we're understanding the biology more and that it's going to help us with time. But this is not like some other diseases like, let's say, chronic myelogenous leukemia, where the vast majority of patients have a single gene that's affected, you know, in the Philadelphia chromosome, and we can jump in at one point. So I'd be worried about us spending so much effort and energy in clinical trials, but in different centers that have the expertise, I think they'll engender enough information to then be shared so that we can do it on a perhaps more broad level in years from now.
Yeah, no, I agree, Joe. I think the important thing is that, and I do think in clinical trials the information's useful. Again, the point, or hopefully will be. So I think collecting, and you know, perhaps not necessarily processing everything to the point that you make about cost, but at the same time collecting data. And I think that the concluding statement here, Brian, is very provocative. Yes. Targeting mutations is futile because the emergence of resistant clones will continue. I think that is true, but as we all know, you know, one of the arguments has been, well, now you've got the monoclonal antibodies, you don't have to worry about this, surely, because it's going to just take care of it. Not true. We know that the antibodies have been greatly successful. We've seen super responses, but we certainly don't know that it's the sort of game changer where targeting mutations is going to be futile. To your point, I'm struck that, you know, we do have drugs, for example, that target BRAF mutation. My own personal experience from patients who participated in those trials is their responses are transient, interestingly. So I think they're short-lived and they have to be part of combinatorial strategies. So I think that targeting mutations is not futile. I think it is worthwhile. But again, it's a matter of the practical. So I think collecting it in clinical trials is important. Clinical practice, I completely agree with you. I think we have to wait and see. And in terms of the preferred method, Brian, I mean, I defer to the experts in the field there, and myself being something of a novice when it comes to these particular technologies, but I'm assuming the technologies that will make the most sense are the most robust, the cheapest, and the most reliable in terms of reproducibility and validity.
So, yeah.
One aspect I would like to add to this is that I agree with the thinking to bank samples.
Yes, exactly.
That's important. So I do also think that not only to select drugs could this be good for, so this could also be good for monitoring low-level disease, obviously, and we even set the diagnosis. So we have done work in the laboratory when we did the bone marrow aspirates, we lysed the cells, we took out the DNA, we sequenced the tumors, and then with half a milliliter of plasma, we picked up the same DNA signature.
Right.
So you set the diagnosis in a very small amount of DNA in very low level of blood, or low volume blood. So in the future, if we could develop those types of technologies, even if we're not talking about targetable mutations, you could think of, you could have liquid diagnostics. These are fantastic opportunities for the future. You could monitor.
I do like that idea, especially like the idea that you would be targeting, and we'll come to this topic, minimal residual disease. So for example, what are the mutations in that population or populations that are left after therapy? The persistent MRD, those could be helpful cell populations.
I think the same technologies can be used for many purposes. They can be done to find targets, they can be fine to set the diagnosis, they can be fine to monitor, they can detect early relapse. It's the same technology, it's just used in different ways.
Yep.
Right. Okay, so a lot of discussion about this, and just to mention, there were certainly some people who opted for OR to say that, you know, we're not quite sure what we can get out of this right now, but I think most people were certainly on board with the studying and the banking and maybe some select trials. Okay, so another very, very big topic recently and certainly at this summit was where are we with minimal residual disease, MRD. And so obviously this has come about for a couple of reasons. One is that we do have methodologies that allow us to go beyond measuring monoclonal proteins in the conventional way and just simply looking at the bone marrow to use sequencing or next generation flow techniques to assess the bone marrow and also to use more sophisticated imaging. So we have tools that allow us to assess at a low level, but we also have the therapies which are getting us down to those low levels. And so the topics that came up for discussion were really how do we define the MRD, who will really benefit from this type of an assessment, and how do we really use the MRD status information? And Dr. Shaji Kumar reviewed some of this information for discussion with us. And so he discussed the tools, the flow cytometry and imaging and the sequencing and the bone marrow, and then the imaging techniques we currently have. And we have, as a group, now come up with 3 elements that could be used to identify MRD negative status. So there are 3 ways in which this could occur. One would be using sequencing, one would be using next generation flow, and one would be using imaging, which is perhaps the least secure right now because we don't have high-level standardization in the area of imaging. However, we are moving towards standardization with both the flow and the sequencing methods. And so the first step is to integrate this type of an MRD endpoint into our conventional response criteria. So right now we have complete response in which the bone marrow is less than 5%, and we have negative immunofixation for monoclonal protein in the serum and the urine. Right now we go to stringent complete response where we have a normal free light ratio and no clonal plasma cells in the bone marrow. And the concept here is that we would now have a new category which would be MRD negative using those 3 elements, flow, sequencing, and imaging. But a key point, which was discussed a lot back and forth, is that that would happen, but that would also happen, is that we would shift and no longer use that stringent category and shift over to use the more precise MRD negative endpoint. And I believe that we had some consensus on this particular point. And then the question that I'm moving towards is, let's say we do have consensus on this point, how are we going to use this and what are really the key questions? The key questions will relate to MRD being negative or MRD being possibly positive, and what are the kind of trials that would come up related to that. And so my question for you guys, and you can decide who would like to touch on this one first, are as follows. So we have MRD testing, and we can find out if someone is positive or negative in the bone marrow or on scans. What is the most important information? To have that negative status, or maybe to look at that patient that's MRD positive and think about developing some better therapy? Or if there is some residual disease, maybe that has an MGUS-like pattern. Is that maybe one of the key things that we should be looking at? So who would like to touch on this first? Joe, you want to touch on
Yeah,
that?
no, absolutely.
Okay.
No, I mean, I think it's another very important step forward, first of all, to realize that now we've reached a point where we have enough people in biochemical complete response that we can start looking for MRD status. So I think
Right.
there's absolute consensus there that, you know, that initial slide you showed with the depth of tumor that's left over, you know, the lower the burden, the longer in general it's going to be before it comes back, and we might even be able to get to a cure. I think where we have the challenge is, going back to what we just had, the discussion around biology, is that MRD in one patient is different than in the next patient. You know, paradoxically, some of the patients who have lived the longest with myeloma have never been in a complete remission, let alone an MRD complete, MRD negative
they maybe
complete
have
remission.
this
That
MGUS
MGUS-like, you know,
pattern.
where they go back to their MGUS state. Now, granted, I think that's only 15, maybe 20% of patients maximum. So it's still a small number. So the majority are taking us there. And I think that is important that we say, you know, a lot of times our treatment modalities have been rather empiric, meaning we just give 4 cycles of an induction therapy, because in the old days we gave adriamycin and we didn't want to give more than 4 cycles. 4 cycles may not be enough. You know, with a lot of these, despite what we talked about, these very powerful drugs that can get people into deep response, some people need longer, and we're learning that from some of the recent, even carfilzomib lenalidomide DEX studies that Ola and others have done, that some people get to that after more cycles than just 4. Most of them happen quite quickly. So I think the principle is there. The second point to me is that the practice of it, I think we're speaking in more common currency now.
Yes.
When we had this discussion a year ago, there was still differentiating flow techniques, differentiating next generation sequencing. And when the two of you were so central, yourself and Ola, central to having a summit to discuss this sort of notion, so can we all talk with the same language, I think that has definitely brought us forward.
Right.
Not sure it's quite ready for everyone in prime time, but this is the sort of thing that we can start including in trials now, that as certain centers become more accustomed to using it, will eventually diffuse it out into the general hem-onc population.
Right. Paul, what do you see here?
Well, what I see here is, again, to echo Joe's point, is steps forward. I think, having said that, I think that the goal of MRD negativity in every patient needs to be approached with caution. I'm particularly struck with the point you made, Joe, which is that we have a proportion of patients who resort to a biology where they can have essentially an MGUS pattern, and it is there, it's real, we see it. I think that, having said that, the goal of going from stringent CR to MRD negativity with the use of imaging to back up the quality of response assessment makes great sense to me. I think one thing I do get a little concerned about is the application of MRD negativity in the clinical research setting, which I think is very legitimate, where obviously the imaging is part of the trial, it's funded and so on, to bringing it to everyday practice.
Yes.
And so I find in everyday practice, I like to give patients sort of surrogates for this. You know, I do think stringent CR helps in that regard. And I think biochemical status does help. I mean, we mustn't lose sight of that. But I think, again, where it becomes really interesting, and I think, Brian, you're going to come to this, is as we develop this tool, what do we do about MRD positive disease versus MRD negative from the point of view of treatment?
Yes.
And I think that, you know, Ola made the point very nicely a little while ago. You know, multiple myeloma is just that. And what I'm always a little bit concerned about is the therapeutic choices that are made around being positive or negative that may in fact lead us down pathways for certain individual patients that might be problematic. And what I mean by that is, you know, if you have an MRD positive patient, I think it's very clear what you have to do. I'm a little bit nervous about what MRD negativity means in terms of treatment. Do you pull everything off and step back? Will our regulators say you've got no justification for expensive medicines in that setting? And I think, you know, we need to be very careful how we approach that from a research standpoint.
Right. So I think a key element to this, which is very important for
Yes.
the patient audience, for example, is that these things we're talking about are at the clinical trial level, really,
Yes,
where if we have a negative result, we need to understand, is that going to be sustained? Does that mean we can safely stop treatment? Or as some people mentioned here at the summit, that kind of patient, you might want to even push a little harder to make sure that it truly is sustained, to continue with the maintenance. And then conversely, you know, we certainly need to understand and understand the MRD positive patient in terms of therapy. You know, what should we do? Switch immediately, and then if so, to what? So what are your key takeaways for MRD at this point?
Well, I think Joe and Paul summarized a lot of the important pieces here. Maybe I could add some little detail. I think that why at all do we have to think about it? I think one of the driving forces for sure is that the new therapies we have now, they are so good. So the vast majority of patients are either reaching a complete response or close to a complete response in the newly diagnosed setting. So if we don't start developing these types of tools, we won't be able to monitor and measure how good the therapies are in the future. So we really need to do it. So I think that's important to say. I also think the first question here is, are we achieving a true negative, MRD negative status? The way we currently can measure MRD is not an arbitrary yes, no. It is a quantitative measure, and all the technologies that we do have now, they have different types of sensitivity. So that's the reason why if we use different types of tests in the same individual patient, that some tests could be positive and some could be negative. And there are factors beyond that. The disease is not equally distributed in the body. So there is a lot of confusion. And there is no reason to panic as a patient if a test is positive and then negative, or one is positive.
Very, very key message.
So I think on a practical note, these are very low-level disease and have to be handled with care. It's a little bit like the imaging story, like maybe retest it one more time and see where it goes. Not act on it right away.
Yeah, so I think that is still definitely at the assessment stage. And I was struck by one piece of data shown by Bruno Paiva, who was looking at the difference between 10 to the minus 4, 10 to the minus 5, 10 to the minus 6, so that when you go down to 1 in a million or even 1 in 10 million, do you still pick up cells? And the answer seemed to be yes. That 5–10% of the patients were still having some cells floating around there.
So that, and I think that's another sort of simple take-home message: is MRD negativity does not equal cure. I mean, we're not, you know,
it's a step, but
yeah, it's definitely. You know, I use the analogy with my patients in the room. I say, oh, this carpet looks really clean, and we vacuumed it really well, but you know, at first pass it looks clean, and now we have better detection techniques. But if I get a little wet Q-tip and go down there, I'm still going to find dirt. And so the smaller and the smaller the Q-tip, the more and more dirt we could still find. But it's definitely, as we said, I think a big step forward. I mean, if we aren't doing that, we're going to be missing more disease. And I suspect when we have this kind of conversation in another year or two, we'll have even better techniques of detecting that 1 in a billion as opposed to that 1 in a million, and so on. So that will be helpful. But just because someone is MRD negative, I think, Paul, you said it, we don't necessarily get a false sense of security that, oh, the disease is gone now. Because we've learned, I would argue, maybe MRD status is most important in high-risk patients whom we know the disease can grow back very quickly. And in some of those patients, we just unfortunately can't take our hand off the pot, or it'll bubble over very quickly. But this can be very helpful in determining maybe how aggressive we need to be, or is it time to switch if we keep, you know, treating some patient that still has persistent disease. It might be a time to change course.
Okay, great, very good points. Okay, so a big topic, and this leads into a major area right now. We have so many new drugs coming along, and we have patients who have used and unfortunately are relapsing after using some of the recent novel therapies. And so we now have a challenge where patients have become refractory to the thalidomide and Revlimid and pomalidomide class, the IMiD class, and then also refractory to Velcade and carfilzomib, the proteasome inhibitor class. So the challenge of double refractory disease was discussed at this summit by Dr. Mary V. Mateos from the Spanish team. And so the current definition of this double refractory is, you know, those who are refractory to the bortezomib class and the lenalidomide, and then also the second element where there's a failure to achieve at least an MR and progression on current therapy or within 60 days. And so the question that Mary V asked, which I thought was really pertinent, is, you know, what do we truly have to offer this double refractory population right now? And so I'll just take you through some of the more recent information that we had from ASCO. So obviously there was a lot of excitement about the Eloquent True trial, which is obviously the assessment of the monoclonal antibody elotuzumab with or without lenalidomide and dex. And so, but important to point out here is that this was not in patients with relapse refractory disease. It was in earlier disease. And so this phase 3 trial in patients with 1 to 3 relapses showed substantial benefit both in PFS and survival in this population. And so a lot of excitement about the added value of the elotuzumab, and especially this point which has been discussed, that the patients are having a more sustained benefit, and so longer PFS at the longer time points, which was another aspect for discussion. But relevant to the double refractory, I think that there was truly much more significant excitement about the anti-CD38 patients, the SAR compound, but particularly the new data that was presented on daratumumab. And this was really where we were looking at this double refractory population and really seeing some significant results. And the results were presented in these different categories here, looking at patients who had had different combinations of prior therapies. And so, as was emphasized by Mary V when she was reviewing this, it really impressive to see as a single agent the remissions and the survival in this double refractory population. And so if we go a little bit further, does this type of efficacy represent a model of what we're trying to achieve? I think that we had a lot of discussion about how do we evaluate benefit in this double refractory setting. We talked about the results with panobinostat. And so, but here we have, I would have to say, a more decisive benefit. But is this the kind of benefit that we're looking at to encompass a true unmet medical need? And so, number one, do you agree that this is really an important drug in this setting? And is this the kind of thing that we really need to be looking for? Paul?
Well, you know, obviously both Dara and Elo are very near and dear to our hearts, because the Elo story begins obviously before Dara, and I think what's particularly attractive about Elo is to see the success of a rational translational effort in which, when we used elotuzumab as a monotherapy, the best we saw in relapsed refractory disease was just stability. When we put it into overdrive by combining it with immunomodulatory treatment, which was informed by laboratory observation, to see it translate into this trial result, I think was very gratifying. And I think for patients it's incredibly important because, as you pointed out so nicely, Brian, the clinical benefit seen, recognizing that the overall result was 4.5 months or so, the clinical benefit in particular groups was particularly striking.
Yeah.
And what I think jumped out at me, which I think is very important for patients to appreciate, is that for those patients who achieved complete response,
Right.
if you got the 3 drugs versus the 2, there was a substantial difference in terms of clinical benefit in favor of the 3 for
Right.
duration of disease control and progression-free survival. So that was particularly striking. What was also very striking was the clinical benefit seen in the adverse cytogenetics, very much mirroring what we would expect. And then the secondary endpoints of response difference clearly supporting it. So a very positive trial. I think elotuzumab will be the first antibody approved on that basis.
I've given you one scenario here, but this other scenario is equally important, where you have an added benefit in an earlier disease setting, in a randomized trial setting. And a key point in certainly the way that I'm looking at that is that we have an advantage with a new class of agent. So an immunomodulatory agent.
Yes, exactly. As an antibody, yes,
Yes.
exactly. And I think the DARA data are very striking. And again, they reflect what was seen in the phase 1, but recognizing the phase 1 populations highly selected. This phase 2 experience that was multi-center provides an accelerated approval platform for DARA, I think.
Right.
You mentioned panobinostat, and I think it's very interesting because, again, if you start to look at subgroups, when you look at the panobinostat data and realize what the FDA was so constructive in dissecting out from the panobinostat study was that those patients in whom immunomodulation and bortezomib-based therapy had failed them, that was the group in which the progression-free survival was most striking. And actually, it was 6 months.
Yeah.
So I think these studies tell us a number of things. I think they tell us that, you know, with new mechanisms of action, that's where the sort of breakthroughs are coming.
Right.
And I think that daratumumab single agent efficacy is striking. We know that when you partner it with other drugs, there's even more excitement to come.
Right.
And ELO has already established that and will be kind of first through the box, as it were, or out of the box in that regard. But DARA will be hot on its heels, and I also would predict that isatuximab or isatuximab is the new name for SAR.
Okay,
I'm actually glad because
it's got a name.
Well, we used to call it DAR and SAR, didn't we?
Yeah, DAR and SAR.
And I think now it's daratumumab.
Think of Isa wearing a tuxedo.
I love
Yes.
it.
Isatuximab.
Isatuximab,
All
and
right.
it makes great sense. But I think isatuximab will also emerge in that same
Right,
context.
same.
So I think very exciting, Brian. Very
Yes,
good news.
yes. So what's your reaction to this? Obviously, I've given you one example here with a single agent and the unmet need, but also the combo earlier. Yeah.
I mean, I think it's great. I mean, I agree with what Paul's saying. I think there's kind of two ways I look at this. The phrase unmet medical need has a very defined purpose, right? This is looking at a regulatory pathway for a drug to be approved, and those are the rules of the game. That's the way the game gets played, and we want to play that so that we can jump through the hoops to make sure we have better access for better agents for our patients.
Right.
There's no doubt. How that's exactly defined, I think the phrase double refractory is going to have to go away eventually,
Yes.
because now it's very complex. There's all these different agents, and double means something to somebody else as to, even if we just
Triple,
confine it to the
quadruple.
United States, right? Because really the double refractory unmet medical need was being met by some degree with carfilzomib and pomalidomide.
Right.
So in fact, now we have, as you showed with the DARA study, as we can with isatuximab, you know, we have these quadruple refractory-like patients. So there's the regulatory way, and then there's just the way of thinking about what is going to be good ultimately for our patients. And I think that's what we're excited about, is that we have a different mechanism. We can approach the disease in a different way. And maybe one of the things we haven't had a chance to say yet is with these monoclonal antibodies, in particular elotuzumab and the anti-CD38s, not that every drug has some risk, obviously, and there's always adverse events or side effects from any of them. The kinds of side effects that we see from these drugs are not typical of the ones we've seen with the other drugs.
right.
They don't have what I call overlapping toxicity, so the ability to combine them is enhanced. Not just because biologically they work together, but we can combine them. And now the data that we're seeing of combining DARA with lenalidomide or
Very
isatuximab with bortezomib,
exactly.
these kinds of studies are very encouraging to us to be able to bring us further along the way.
Right.
And Joe, to your point, what was very nice in the ELO trial was to see that the efficacy signal from both over the age of 65 and under the age of 65 was the same. And what was also particularly striking was actually, if you drill down on the adverse event data, very similar. So certainly speaking for elotuzumab, its tolerability is quite striking, and the rate of infusional reactions is really quite low. So I think I completely agree with you. I think it's extremely exciting and great for patients. In terms of the new terminology, Brian, I think we have to be a little careful, because I think that double refractory means clearly something in terms of a regulatory pathway. And I think we have to very much engage here with our regulatory partners and our pharma partners to make sure that there is a unanimity of understanding. Because I thought what was one of the most encouraging things from the summit, and again, enormous credit to you for organizing it. I think it's one of the highlights of the year, in my view, is that we get people together where we can have these discussions. And I think the discussion that both Joe and I were at yesterday, I thought was very fruitful, because we recognize that double refractory means different things in different countries. And I think we're going to probably have terminology which is broad and then drills down. So we're going to have sort of essentially, are you refractory to the IMiD class, are you refractory to the proteasome inhibitor class, and which agents, recognizing that IMiDs are different.
They're not the same drugs.
Potencies are radically different, and also, of course, in the proteasome inhibitor world, it's even more stark because they are clearly different drugs. So I think that we'll have that. Then I think there's going to be the next category, and we discussed this at the session this morning, which is now we're going to have refractory to next generation new mechanisms of action. So as we go forward, how are we going to address...
The complexity becomes mind-boggling.
Right, and actually we're going to have patients who are resistant to monoclonal antibodies. So that, and to me, if you have a single agent that is able to overcome, the so-called quadruple refractory trials where patients have unfortunately had IMiDs, proteasome inhibitors, and second generation carfilzomib pomalidomide fail them. If a drug has a signal in that population, that's a very provocative sign. Right. And I think we'll have antibodies and HDACs coming into that same space.
And that's part of the element of this question, is that if you have something that's working in this setting, that's very important.
Right.
So I think this is kind of a paradox. So as we are moving into the future when drugs are better and better, it's getting harder and harder to get them approved because the competition is tighter. Yes. And this, I agree with everything you say. The rules are set up by the federal agencies that regulate and approve drugs, and we have to have rules. Right. But on the flip side now, if you look at the prevalence of patients with this disease, 5 years ago, I think there were 55,000 patients living with myeloma in America. I think this year there are 86,000. And the projection is in 5 years there will be maybe close to 100,000. And this is because there is no cure for the disease that can be guaranteed. Right. So clearly there is an unmet need to develop an established cure. And now we are talking about the problem of getting drugs approved. So this is the ethical dilemma.
Right. And so, as you know, we're going to be leading into this in just a moment. I was making note of these triple and 4 and 5 drug combos that you were ending up discussing there, which have significant financial implications.
Brian, if I may, one sort of last point on this is I do think, and particularly speaking for the FDA, they are very, very, I think, engaged in the myeloma space, and I think they've been remarkable partners. I mean, there's no question. And what I saw them do in terms of helping with panobinostat was unprecedented. I mean, they stepped in and sort of said, we see you've got a positive signal, let's sort this out, despite an ODAC that, on the face of it looked like, no way. They actually went in and said, wait a second, here we are. And I was very struck by that they basically said, you've got a double refractory population and you've got a novel mechanism of action. So they drilled their approval down into that. And I wonder if that's what we're going to see, that essentially what they'll say is, you can have double refractory, we're not going to raise the bar too high because it's going to become impossible. What we're going to say is, if you've got a novel mechanism of action, are you offering the patient something that's completely different? And I think that's going to be a very exciting new avenue for drug approval.
Absolutely, absolutely. So one aspect of this I just want to touch on before we move forward is we've touched on the elotuzumab, which we're obviously excited about, the daratumumab and the SAR. I'm going to stick with the SAR for now.
You can't think of Issa wearing that tuxedo?
Beyond that, I've given another 2 or 3 things there which are exciting, and we heard lots of different ideas about what would be the most important next thing. So maybe each of you could give me, beyond the top 3, what are the next couple of things that you view as the most exciting? So we'll maybe start here. Ola, what do you think? Beyond the top 3, I've given you some examples there, but what do you think is the next couple?
So can I only pick one, or
2? We'll give you, let's start with 2. Let's start with 2.
Well, I mean, I think that because drug development is complicated, I think we have to risk spread for sure. So what we are working on is CAR T cells. Okay. We will probably have CAR T cells coming to clinic within 12 to 18 months at our institution.
No, the recent results were with the CAR T19 population. And so is this what you're talking about, or are you talking about the other?
We have other targets that are tumor cell specific. And we have also manipulated them in other ways.
So just so that we're clear, so obviously in the CAR T19, this is something that affects about 4 or 5% of myelomas, which are typically CD19 negative, but 4 or 5% are CD19 positive, and so the activated T cell therapy has been actually remarkably effective in some of those patients. But so what percentage of the patients might be affected by your newer therapies that you're describing?
Are we talking about potential candidates who could be
Yes.
attacked? So
Yes.
if we were to screen patients for the antigens that we are planning on targeting,
Yes.
probably 60 to 70% of the patients
much
could
broader,
have those
applicability.
targets. But we need to do a little bit more work. Another, my second choice, and I'm not kind of ranking them here, but you said I could pick two. So I do think that it's also exciting beyond just looking for new targets to also to look how you can go after a target that we know works. And one of those is to inhibit the proteasome.
Okay.
Because we know plasma cells are very dependent on the proteasome. We have been working, and I've been working together with Paul, we are working on a joint project with early drug development, inhibiting upstream of the 20S proteasomes. We are blocking the 19S proteasome unit.
Okay.
And that seems to work even in the lab when the tumor cells have been exposed to the carfilzomib and Velcade. When we give these drugs, they still die. So now we are using this in the clinic. So we have a new trial. I'm very excited about that trial.
Okay.
And if I may, just because it bounces
Okay,
off,
so
and I
all right,
apologise,
so-
Joe, for jumping
all right,
in.
so-
And because you
so
can
Paul,
bring
you're
in-
next.
Well, no, only because we've got this super partnership with Ola on this DUB inhibitor concept, and I think it's very exciting. I think, as we think about the other that you have in this category, I completely agree with Ola that there is more to be exploited from proteasome inhibition upstream, and very interestingly, there is the recognition that our current armamentarium of proteasome inhibitors primarily target the beta-5 subunit, be it bortezomib, be it ixazomib, be it carfilzomib or aprozomib. There is a new game in town, relatively new, arguably a little bit old. It's coming through slowly but surely, and that's marizumib. Marizumib hits beta-5, beta-1, and beta-2. And what's so interesting is that when you actually model this, the proteasomes upregulate beta-1 and beta-2 to counteract beta-5 inhibition. Well, this molecule hits all three, and it's in the beta-lactone class. And again, informed from the laboratory, we've partnered it with pomalidomide. And in the laboratory, it's the most powerful of the IMiD proteasome inhibition synergy that we've seen. And clinically, it's funny, I was just with Andrew Spencer, who's a part of our trial, and everybody in the trial, Ashraf Badros is part of it, there's a great team. Everyone's stunned. We're basically seeing with marizumib POM response rates that are, every single patient treated so far has responded to this platform. And so I think there's a lot more that we can exploit from the proteasome inhibitor pathway. And then, if I may, just for my second choice, I would simply say that the other area that we're particularly intrigued by is the checkpoint inhibition story. And I think, good for you, Brian, for having it up here. And I think we heard so nicely at the summit from everyone about the quote-unquote Achilles heel of immunotherapy and myeloma. And I think checkpoint inhibition, not on its own, but in combination, is going to be very exciting. And I'm sure, Joe, you can comment more on that.
Yeah, well, we've been doing some work with checkpoint inhibitors as well. I tend to agree with you. I think on their own in myeloma, they may not be that potent. You guys haven't left me much left. Actually, no, there is a lot left. So just following the proteasome inhibitor theme, let me just also remind us, because they're not on the list, the two drugs that you mentioned, they may not be scientifically a massive step forward, but for patients, a huge convenience step forward have been the oral proteasome inhibitors.
That's very true.
So ixazomib, which is really an oral version of bortezomib, and oprozomib, which is really an oral version of carfilzomib. Although I must say, in one of the studies that we did, we took patients who were refractory to carfilzomib and treated them with oprozomib and saw a signal. So I'm not sure oprozomib is exactly just oral carfilzomib. And because it's there on the list, the selinexor is a drug that has been a bit of a challenge for some patients, for sure, especially in lymphomas. But I think we're learning ways to try and overcome that, some of the GI problems that they've had.
And so in combination with DEX.
Absolutely. And then lastly, just on the monoclonal antibody theme, the other target that is quite prolific, maybe not as prolific as CD38, but CD138. And so now doing some early work with some of the anti-CD138 inhibitors is showing promise. So I think the message really is we've got a lot of promising targets and agents at various stages of development. And I suspect if we have this conversation again in a year from now, your list is just going to get longer and longer, Brian.
Well, I think it is, and I think one last comment, if I may, Brian. Just as we saw the ultimately, the getting across the goal line with panobinostat, we've also been very impressed that there's a next generation of HDAC inhibitors that are more selective, better tolerated, and arguably potentially more active. And the other trial I'm very excited about, in combination with pomalidomide, has been our experience with the AC1215 and POM, where certainly in our own experience, for our own cohort of patients, the responses have been remarkable. And what's really interesting is the tolerability of the IMiD plus the HDAC has been striking, whereas some of the more challenging side effects that we've seen from combining the HDAC platform with proteasome inhibition, which has been so synergistic but so challenging from a tolerability point of view. When you partner these drugs with the IMiDs, it's fascinating. We're seeing excellent tolerability from an all-oral regimen, and in our own experience, particularly with the 1215 POM platform, the responses have been dramatic. So I think you're absolutely right, Joe. I think there's a lot coming. And I think the challenge for us as investigators is how on earth we make sense of all of this. But I would say one thing, it's clearly not a zero-sum game. I mean, we're very clear about that. Patients often ask me that, where do we go? We need all of this, because the reality is I have patients in whom daratumumab fails them. Yes. I have patients in whom elotuzumab fails them. And I'm sure, Joe, you've had the experience with SAR.
Clearly an unmet need. Yes.
Absolutely.
So maybe we'll not all answer this question, but another topic that came up just to touch on is that in this setting we have increasingly patients who've gone through these different novel therapies but have not had full exposure to the alkylators. And so there was discussion at the summit here about alkylator therapy and the use of stem cells transplant in more of the salvage setting, and patients who maybe have had a lot of novel therapies but actually never did have a stem cell transplant. So do you look at that as one of the options possibly in this more relapse situation?
For sure. I had the privilege of being involved with 2 of those studies where we looked at using a salvage second transplant. So that's another, sort of a theme in myeloma, of course, is that you can go back to a drug that's been used before, especially if it worked before and had a period of time. So you're right, there are a lot of patients now, especially older patients, for example, in whom we're not giving the melphalan early on. Right. A lot of these patients end up going through a lot of novel therapies, as do younger ones who may avoid transplant or have a single transplant. That I do look at this list. I mean, I tell patients it's not a game, right? But I want every card available to play. I want to play the best card for my patient, but I also recognize that I have other cards to play. And in some patients, I had a patient last week in clinic, he went 4.5 years after his first transplant with no maintenance therapy. 5 years ago we weren't using it as much. And he said, well, we banked enough stem cells, and can I have a second transplant? And why not? Because it's likely that he'll at least get 50, if not 70% of the time that he got after the first one. So in simple answer, I would say yes, Brian, it is an option. I think there are challenges in using alkylators, challenges using them a lot up front because they can be tough on the bone marrow.
Right.
But as an option later, especially in combination, be it cyclophosphamide or melphalan, I think these are agents that we will still be able to use. Like Paul said, we don't want to give up anything we've had. We want every option on the table, because more options means better options for our patients.
Yeah. So talking about having every option on the table.
But Brian, if I may, just as I'm so sorry.
I know where you're going.
No, because we're almost getting there. But I just want the reason I wanted to just chime in very quickly on that, because it's something again that Ola and I are working together on, is the recognition that there are new chemotherapeutics that have the opportunity to be less toxic, especially in terms of stromal injury and stem cell damage. And they're teaching us some very interesting things. And at the EHA meeting is being presented data from an international study group looking at a new melphalan derivative called melflufen. And I have to say the results are striking, to your point, that you can revisit. And one can argue, have you reset biology of disease? Because what you're doing is you're treating with novel biological agents, and then you can come in with a novel cytotoxic and see responses. And I think it's very exciting, and it echoes what you're saying about the second transplants. Absolutely. Yeah. Sorry, Brian, I apologize.
No problem. And so, but a very serious topic which was discussed for the first time at our summit was what is the financial toll for all this? Absolutely. We want to have everything on the table, and we want to have access. but there is a cost to bear. And how are we going to be thinking about this? And so I think for me, it was really good to see us becoming engaged as a myeloma community to, for the first time, really try to address this. And so the topic was brought up by our colleague Vincent Rajkumar, who had a very interesting way of displaying where we are in myeloma. We have the drugs that we have been using in recent years. We have the old drugs. We have, this is interesting terminology. These are the older novel drugs. So it's hard to know what to call them anymore because we've had them for a while. And so, yes, they're not really novel anymore. And so then we have the recently approved drugs that we've been talking about, with the most recent panobitastat, of course. And then this list includes a number that we've just been touching on. We have all the, including the marizumab, daratumumab, the SAR. We have all of those coming along, okay? And so where are we with the treatment? We have the mild triplets. And so what Vincent meant by this is that it has a novel agent in it, but it has a non-novel agent. It has bortezomib with Cytoxan. And from a financial standpoint, what is being addressed here is that one has an expensive drug and a cheap drug. So one has a mild, in terms of the impact on the wallet. One then has what Vincent called a true triplet, which is two of the newer agents together, like Revlimid, Velcade, etc., and then moving up to Kyprolis with Revlimid or pomalidomide. And then one has what we were starting to talk about. We have our triplets, and then we add in ELO or DARA, panobitastat, etc. And so this is clearly the way that we're thinking. And so what are we going to do about this? Because the final category is total wallet failure. I mean, what are we going to do here? All these combos are just going to exhaust us, you know, total therapy, you know, 8. We need to have some way to be thinking about this. And so we also need to be aware as a global community that when we're looking at drugs for approval and we're looking at combinations that we might recommend, that are these individual drugs available? Are they accessible globally? And so we need to be looking at that in terms of recommendations that we might make. And in the US, we're actually very, very fortunate. Less fortunate in Canada, UK, and Europe. Asia Pacific and developing countries, complex pictures, co-pay situation in the Asia Pacific with limited access, many developing countries, very limited access to new agents. And, you know, as educators and speakers, we often go to these places, and I have to say it's often quite troubling to be talking about new drugs that might not be accessible. And so the question is, and I've left this question rather open, because I think that we need to consider together, how are we going to start looking into this problem? And so who would like to comment first? Huh? No, I could potentially just keep talking. But
No, I think the fact that we discussed it at the summit, Brian, is the first step. It's just,
yes.
I think so often as physicians in particular, part of us wants to say, I really don't care about cost whatsoever. I just want the best for my patient. And I agree with that concept and modality, but I can still advocate strongly for my patient being cognizant of that cost. You know, especially in this situation, whereas we've heard in some of these countries and places where, you know, people are selling their homes and becoming entirely bankrupt for, we're not sure if it's really adding that much more to the combination. So it's driving us for better science to prove unequivocally what combinations are working the best. But also behooves us because we do have influence, we do have respect to some degree in the community and at the economic levels and political levels to say, we can't be in a situation where what we arrive at in a clinical trial, that here is this great combination of drugs that Professors Richardson, Landgren, Durie, and Mikhael have come up with. Oh, but no one's ever going to fund that, so we can't do it. So we want to advocate for a streamlined process, a process that respects the way our economy works, but also respects the value that it brings to the patient. And so just being at the table, I think discussing amongst ourselves was step one. Step two is us getting at those key important tables. Prior to coming to the US, I was in Canada. I was involved in the committee that advised the government about certain drugs, and it changed, from us just advising, saying the data is good, we should cover this drug, to a point where it was a tripartite table now, where we were 1/3 of the table all of a sudden, instead of being the whole table, with another third being experts in pharmacoeconomics and a third being the government regulators. And that's just the reality of where we lived. But I think that notion is important for us to say we want to be at the table, we want to advocate for our patients, we want to look at what solutions there can be, because these drugs are not going to instantly get cheaper. So if anything, they're going to be more expensive as they're more and more difficult to develop. So
this element of being at a table is a key point, I think. Absolutely. And so there was quite a bit of discussion about that, about creating this table that people would come to and collectively discuss this.
And I think even that we discussed it amongst ourselves just raised the awareness of it. Because I think a lot of times we may not fully appreciate the kind of impact it has on our patients.
But I thought, Joe, that the session, which was a privilege to be part of, I thought Jean-Luc's perspective was fascinating, because he dissected the European mechanism, and I understood things that I had not appreciated before. Yes. And not least was that the German model is driven by the fact that they have a GDP that's the best in Europe, and they commensurately reflect that in how they deal with drug approval. And
but I mean, they were the only country highlighted that was capable of dealing with it in that way.
Exactly. But, speaking to my mother country, to the British situation, with the cancer drug fund that was built by David Cameron, there's, thank God, been the relief of that sort of travesty of the NICE model, which was really so devastating for cancer patients in particular. But recognizing that we're dealing with healthcare systems where the problems are substantial. I'm just reminded of a few sort of simple facts. At the end of the day, drug and device cost for the total US healthcare budget is 10%. 90% is everything else. And as we discussed at the meeting, I'm particularly struck that, for example, in our own Partners Health system, we're investing $2 billion in Massachusetts alone in one system, Partners, for the federally required computer system. $2 billion. That's what we're spending. Now, as we think of it in that context, we sort of have to then frame, well, let's go from the ground up here. Where are our problems in drug development? Where do they lie? And I personally think, from my own sort of granular experience, that in drug development, I'm very struck by how the cost of clinical trials can be exorbitant, and it can be driven by no good reason. We've seen contract research organizations for the same RFA bid at 25 million versus 5 million. This is crazy. And as a myeloma community of invested researchers, and I say invested in the best sense of the word, we're there to get the drugs approved as quickly as we can for our patients, as cheaply as we can.
We should engage and ask them to go from 25 to 5. Yes.
Well, but also, Brian, preserve quality, because what you don't
absolutely.
want, you don't
no,
want.
Please don't misunderstand.
No,
that quality is key.
It's key, but what is the difference between, say, 10 million and 25?
Right.
Huge from a study budget. It would have crippled us. We would never have been able to do the trial.
So Ola, what do you think about all this?
Well, I think that the first step that we could all do, and I think you did so beautifully and initiated here, and we continue talking about it, is to increase the awareness about these things and to continue talking about it, because this is an evolving problem for everybody. If you look in the cancer statistics, a likelihood of a male unfortunately being diagnosed with any cancer, I think 2 out of 3 males between birth and death will have a malignant disease, and I think for females it's 50%, so it's pretty high numbers. So this is not a trivial problem for the population, so we have to just deal with it. Right. So other things I was thinking about is that because the situation is so different in different parts of the world, I think it's obviously not going to be an easy solution. So I think that maybe just the awareness factor is maybe the key thing that we as a group could kind of bring to the table, and then each country and each region probably has to come up with its own solution, I think.
Right.
And another thing I was also thinking about is that we think about all these expensive drugs as a big problem, but I guess you could try to flip the whole story and say, if you really took the best drugs right away, could you cure the disease?
point.
And then maybe the cost would be lower.
And so
Which is right?
And so this was a point that was raised by several people at the meeting, is that we as the clinicians do have some responsibility in guiding towards that in terms of therapy that is really attempting to have that deep response that will have the best outcome, but in a cost-efficient way. And to be looking at that maintenance to say, well, you know, that's going to be expensive. How much of that do we really need to look at a protocol that works well, but also is considering the cost aspect?
Go ahead.
Yeah?
No, I was just going to say I completely agree, and I think that as we think about, for example, regulatory burdens that can be massive, you know, they need to be streamlined and rationalized. As we think about costs of drug development in the broader sense, I'm always reminded about tuberculosis. If one thinks about it.
I can't see it pops into my mind. But
Well, let me explain why. Let me explain why. Because if you think about it, when TB dominated the world, it was the equivalent of $1 trillion healthcare industry. You had sanitariums, you had the morbidity and the mortality of a dreadful scourge.
Right.
Then along came 4 antibiotics,
right.
and boom, gone. So I think, you know, one's reminded, to your point, Ola, that if we get it right with the best drugs, you know,
Absolutely.
costs.
We may not have the same impact.
No, I
as
agree.
TB.
I'm not going to say TB, but
no,
we're
that's
close,
important.
you know.
I mean, some of the
Exactly,
work I used to do is in
That's it.
pharmacoeconomic modeling, and we would
Yeah.
look at these exact things and say, here is a relatively more expensive drug, but if the outcomes are that much better.
Exactly.
So for some of the work, for example, that we did, we were looking at introducing, this was in a different disease, just as an example, in lymphoma, of introducing a monoclonal antibody that actually rescued a significant number of patients from later on having to have a transplant, which was much more expensive.
Absolutely.
So I use the analogy that, you know, are you going to keep driving the old clunker that you're going to keep pouring gas into every month, or have a bit of an upfront cost, buy a, you know, cost-efficient car, and then you're going to save in the long term on gas and maintenance and so on. But that's part of the solution. I'm not sure that's the whole of the solution. I think some sheer advocacy, as many physicians and hematologists in particular in this country have been taking to help see that, as Jean-Luc taught us, sometimes the cost of drug development is more than just drug development. It's really just what the market can bear.
Right.
And the market is different for bringing an Oreo cookie to the store that people are going to spend money for than a drug that's going to rescue someone's life. And so I think there has to be, we don't want to push so hard that there's no incentive to create new drugs. On the other hand, there's perhaps a way to curtail it somewhat. So I think this is a complex issue. Anything economic is complex. Not one strategy is going to solve it, but multiple strategies. And I'm just thankful that we as a myeloma community are one of the few tumor sites, frankly, I think, that have really worked hard to try and come together and start finding solutions and advocate for our patients.
Well, and I think that points to something that's very positive, which is that we have an extremely good relationship with our pharma partners. It's very constructive, and I think there's a dialogue that's very, you know, there's an element of partnership and trust and respect for each other that means that we can engage, and in which, you know, our pharma partners don't feel threatened. This is not an attack on them. This is a rational strategy. How can we make this more available globally? And I'm very struck that in our clinical trials efforts, for example, the readiness with which our pharma partners are willing to provide free drug, and also in other situations to provide drug for people in need. That's a very striking and very, very important, and something that perhaps isn't people aren't fully aware of in the broader community, that how lucky we are in myeloma that there are so many mechanisms to access medicines that are not otherwise necessarily immediately available. But I do agree with you, Joe. It's a very complex equation, and I think that we have to engage it. And I think in cancer broadly, as you know, at ASCO, a plenary session was dedicated to this. And so I think, Brian, your setting it as part of the agenda here was particularly poignant, and I think it was received very well, and I think we've got a constructive platform for going forward.
And I think that partnership with pharma was also appreciated in terms of prospectively looking at trials together.
Exactly.
To
make it
see
more efficient.
What
keep
are the
costs
best
down.
kinds of trials that will
exactly.
get efficacy answers, but also some cost answers as well.
But we need to keep on talking about it now.
Yes.
We started talking
Yes.
about it, so we need to
Yes.
keep on talking about it in our trials and at our meetings. We probably should have a slide for our
Right.
presentations.
And,
say
right.
when it comes to costs,
Right.
this is, even if it's not perfect, at least put some kind of measure there.
But I'm very struck by how in the clinical trials process there could be enormous efficiencies gained. And I think that that's our regulatory piece, that some of that burden needs to come down, because it is just crushing us in the US right now.
This was discussed by several.
Several investigators. There was a unanimity amongst the US investigators that were being buried in this regulatory challenge that is almost impenetrable. And at the same time, however, to help our pharma partners realize that, do we need 600-700 patient trials with all the cost that goes into that, or can we be much more selective as we move to more targeted therapy?
Yeah, so all these different aspects need to be considered a multifactorial solution here.
Right.
So
Completely
It
agree.
almost comes back to what we talked about before, like how to get drugs approved, what the endpoints are, and
Exactly.
kind of takes us all the way back there, like how we're going to design the approval process for the new drugs.
Yeah, exactly. In partnership, recognizing that we've been also very fortunate that our FDA partners, certainly speaking for the US, our FDA partners have been remarkably helpful to date.
And so the partners who've actually helped us with this particular program are now on the screen, and we really, really do appreciate it to have this opportunity to discuss and have people learn what was happening here in Vienna at the summit and in these recent months at ASCO and upcoming here at EHA. And so on behalf of the IMF, I'd like to thank my colleagues here for taking time out of their busy schedule to help think and talk about some of these really, really important issues that are important for all of us. So thank you so much.
Thank you so much.
Thank you for having me.